I'm going to discuss about the strategy and then one cases of the perforation of the RCA. I have disclosure. I owe to my patient in whom I encountered perforations in last 27 years. Some of them were definitely avoidable. No financial disclosures. We all know complications in PCI may be cardiac or non-cardiac. In cardiac may be coronary and non-coronary. In coronary, I am going to today discuss about the perforations, main vessels, distal or small vessels, then collateral vessels, maybe septals or epicardial. So Alice described, classify 1, 2, 3. 1 is just the crater extending outside the lumen. With angiography, it is difficult to differentiate it from the type C dissection. It is usually very small, nothing to worry. Class 2, there is pericardial or myocardial brush without extravasation. Then again, it is most of the time can be tackled with the balloon only. The most important thing is class 3, that is when there is a contrast jet is more than 1 millimeter size, and the worst is devastating is then it opens to the cavity, that too in the pericardium, not in the myocardium. Location wise classify, the 75% perforation are in the main vessels and 25% in the remaining things. Depending on the perforation, what kind of it is, then there may be morbidity, and morbidity may be more. So as you can see here, main vessel perforation, distal wire perforation when we are trying to cross, like in the second one RCA, it is going to the branches, the wire tips. Many times when we are concentrating on the guide, wire tips floats, it goes anywhere. Hard wires, soft teeth wires, jacketed wires, these are the wires which causes more perforations. Then maybe septal or epicardial collaterals. What happens if there is a perforation? The most important thing is to occlude the artery with the balloon. The basic standard of balloon is 1:1 size, 10 millimeter, 10 minute, 10 atmosphere pressure. Don't overdilate it. And if there is hemodynamic compromise, then pressure maintaining is the most important thing. If there is a big pericardial effusion or tamponade, then you can remove this blood and auto-transfuse back to the body. Then definitely can be covered stent. And last but not the least is the surgeon, and if otherwise you can just reverse it, the heparin with the protamine. But before reversing it with the protamine, all the devices from the coronary should be out, because otherwise it can lead to the thrombosis. So let us see, there is a distal perfusion. Now how to maintain? There are perfusion balloons are there, in which in the central lumen you can get some perfusion. And this is the other way when you can keep the microcatheter by the side of the balloon just to give some perfusion, because so 10 minute, 10 pressure, 1:1 size balloon. Then what we have, like at Bombay Hospital, we have Graft Master. It is the old one, bigger size, double layered, but now it require bigger sheath. There are two different techniques to put the graft. One is the block and deliver, that is a single guide. Same guide, there is a one wire and balloon inflated to prevent this perforation. Temporarily we deflate the balloon and quickly we cross the wire by the side of the deflated balloon, and then again inflate the balloon. Then we take the covered stent, deflate balloon. So there is a transiently we deflate the balloon while crossing. And the most important thing is, before inflating the covered stent, we must remove the balloon which is to prevent this bleeding and wire. Otherwise you remove the balloon, wire is there, you put the cover stent, then it is very difficult, practically impossible to remove that wire. Other thing, if you are using particularly the graft master or the guide size is not very big, then you can have a ping pong, that is a 2 guide wire technique. In this, we just put another puncture from the same femoral, other femoral side, then put another wire, guide, another wire, again same temporarily deflate the, you can see in this diagram very well. So this is single guide, this is the dual guide technique. You can see in this guide, temporarily deflate the balloon, put the guide, put the wire, and then before putting this guide, the first guide you have to temporarily withdraw. That should be like hanging in the aorta. So this is the technique we do it. Heparin reversal, 1 milligram per 100 unit, but do not use more than 50 milligram protamine. But this is the last thing, I'll show one case, interesting. 74-year-old male, Hypertensive ACS, totally diffuse LED, RCA giving collaterals to the LED, aorta tortuous, RCS tortuous, RCS calcified, patient advised CABG. I took out the patient from the table, but they refused, I am not going to go for surgery. You do whatever you can do. So I said, okay, let us do, I will do this RCA fix. What a great tool. It's a TARP chest. I am experienced, I have done 25,000 procedure, I will just do cut. So what started, 10:40 I started. AL support, 2 wires, 1.5 balloon. With great difficulty, you can see that guide is going back. I use the guide extension, 1.5 balloon, withdraw the 1 wire and guide extension, and then 1.5, 2.75, 3 balloon. You can see this is what is a balloon is dilated in the distal RCA. You can see here. Here you can see here. And then I am just putting the guide plus, and then there is over this guide plus I did all the ballooning, and then stenting. 2 Zines stent was put. Good is good. 16 atmosphere, okay. 18 atmosphere, no. Then I said, okay, get out. And my assistant said, sir, this is looking less. I said, okay, nothing to worry, I'll just do it 20. I did the 20 or you see. Now that's why it is from where this saying comes, better is enemy of good. And in the cath lab AC, I started perspiring. I said, call the surgeon. All surgeons were in the some Rath Yatra somewhere that day, some conference of the CVTS. Not a single surgeon present in the Bombay hospital. So I get a double perspiration. What to do? First thing is to balloon it. So ballooning, and you can see in the central thing, it is my finger, wrist, same ring. Pressure from, pulse from 80 to 40, BP 80 to 140 to 40. My perspiration more, ballooning not working much. First thing I did is to put the sheath into the pericardium, started auto transfusion into the other line, that is a femoral line I took, venous line, because in case if require pacemaker also, but fortunately did not require pacemaker. Immediately the auto transfusion responded very well. Then I was doing all these juggleries, and meantime the AL guide came back, and that could not engage. So then I could engage with great difficulty with the AR1. I put the graft master 3.519, but still you can see ballooning 10 minute, 10 pressure, 1:1, still continuing. Second grafter, I said it may be little size, so 4 graft master. Still little less, but still 1 p.m. Then I said 3.5. I had 3 graft master, 3.5, 4 I used, I had another was a 2.8, so it's useless. So I said what to do? I put another Zines stent. This is I have done first time in my life, because nothing is left. Let us try, it may do something, miracle, nothing, still. Then again ballooning, and then 2 p.m. after this, removing all the guide and balloon, giving the protamine, patient is okay, all right. And this is the most important thing was this, you can see pulsus paradoxus. It is easy to present here, but difficult to feel it. You can see this is the Favara fountain. This is at 2 p.m. This is at around 11 o'clock or something. So this is how we did this great vessel. Now the small vessel perforations, again the balloon inflation is most of the time is okay. It may be in the small vessel, 1:1 size, 10 atmosphere, 10 minute, or maybe at the origin of the artery, small vessel which is bleeding, just close the mouth. There can be, we can put the coil or fat or clot embolization, or we can put a cover stent here. But if you put the coil, there are different sizes available, 2x4, 2x4, 2x2, and it wait for 20 minutes because they swells and it takes time. And there are pushable, there are detachable. So detachable, but they are very costly. But the advantage of detachable is that you can replace all these things. So ballooning and then drug covered stent or maybe coil embolization. So this is one you can see here, LED plasty, and this is distal wire. So the good technician, not doctor, good technician is when the operator is concentrating on the lesion, he should keep this thing in the, In the one frame, the guide and the distal tip should be seen in the one frame. That is the job of the technician. And assistant job is to see the distal top tip of the wire. That's why I always say, I don't do this thing. I have not done. We have done. We. I is मैं. Who does मैं? Ma. And then finish. So this is branch, RV branch. Just settle with the balloon. Another case, LAD-plasty. Again, concentration on the focus. Arjun ki aankh. Arjun, then machli ki aankh. Arjun dekh raha hai. So that is how. And then somebody assistant should see what diagonal wire has done. Perforation here. Putting the coil. Everything settled down. But again, there are differences. You can see here. Balloon. Close the main balloon. Side branch bleed may stop. Or maybe like A, B, C, D. Then there is a balloon. You can put the other wire also here. So distal, proximal to the branch, anything can be done. Like here I have to put the covered stent here. So covered stent in the main artery at the origin of the small vessel, so it stops there. As we discussed about the aorta also, the covered stent can close the artery. Here it is the coils you can put, but again make sure that coil is proper. Coil is costly, so you can use the some clot also, you can use the fat also, but dissolve that fat or clot into the dye so we can visualize. Otherwise it is very difficult, they are beyond your control. And this is another case about the perforation. This is the patient had problems, another patient had a left main aortic dissection, perforation, again hypotension. We were keep on looking in the heart. Then after some time we realized we took the shoot and it is the femoral perforation which we could finish it very well. So prevention is better than cure. Prepare the bed properly. Avoid oversized stent. Always look for the guide for the distal tip, particularly with the hard wires, particularly those are the jacketed, polyjumper jacketed wires, all these things. And once the difficult wire is made to cross the difficult lesion, it has finished, exchange to the normal, your workhorse hours. So take home message, tool and team, T&T. Simplifying a complex art is a lesion and avoiding a complexifying lesion is a bigger art. Prepare the bed properly. Do good job, but remember better is enemy of good. Lalach buri bala hai. Know and keep your all the tools, including surgeon. That day, because we have produced all these things, put the stent, so rota would have not hurt. I did not had IVL machine also. So that is, we should always remember. Be fast, but don't lose your cool. Teamwork can save the life. Thank you. Cross is better than other because it is the size of the catheter, the lumen, when you can press it. So this is, you can say this axiom is on 0.014 inch, fine cross, 1.8 French, and the prograde is 2.8 French, azure terumo, that is, but wire is again 0.018. So it depends on what is the size of the guide. Rather, I would discuss more about this size which we usually see this, because this major big arteries are very common now, perforations. Just a minute. This slide I would like to put some more light. Yeah. So this again, how many you have this papyrus? And there are now Chinese tribes are there. They are. It is available because we have, and that there are Chinese devices there. They have used from the tegaderm. They have used a cover stent. They just take the vein. So there are many things which are coming Chinese, but they are not still approved. But they are on the way, so they may be cheaper. But graft master is genuinely is very difficult to require bigger. You can see the size, bulky catheter, and 2 wire, 2 balloon. So a couple of points I will just try to reiterate again. One thing is that before putting covered stent, remove all the stuff, because when there is a wire, balloon, you are in hurry. When all are sitting here with some cold, it's okay. But when perforation occurs, you are perspiring differently and you become like anything. So just removing, putting. So always before inflating, check that there is nothing outside the covered stent. Other thing is that before putting protamine, that is the last thing, you should always be very clear that all the devices, nothing is there in the coronary except the guide, nothing should be in the system, because thrombosis and then can be the double-edged thing is there. An important thing is there, even if perforation, like this was a big perforation, but the moment pressure come out, I was relaxed. It is a question of hour, 2 hour, 3 hour, so nothing to worry. No surgeon was there, so I have no option. So I started at 8, 10, 40, maybe around 11:30 I had a perforation. So 2.5 hours it took to close this. Even if it would become 5 hours, yes, come. Dr. Trihan has come. Okay, no problem. We can continue 4 minutes also. So your comment, anything? Or any participant, just share experience, panelist? Because this is the place we can share our complication, our these things. Dr. Ajit, yeah. Yes, please. You can come here. Two covered stent.